Hello and welcome to Everyday Oral Surgery. This is your host, Dr. Grant Stucki. I am an oral and maxillofacial surgeon practicing in Denver, Colorado. The goal of this podcast is to connect, learn, and inspire. In this podcast, you'll be hearing from OMS surgeons all over the globe discussing ways to improve the practice of oral and maxillofacial surgery. Most information shared in this podcast will be based on personal experience and opinions, so please supplement what you learn here with approved research studies. Without further ado, please enjoy today's episode. All right, welcome back to another episode. Today I'm with Dr. David Salomon. He's an oral and maxillofacial surgeon practicing in Connecticut. Dave, thank you for joining us yet again on the podcast.
Glad to be here, Grant. Thank you so much. Always a pleasure.
Yes. I got some great feedback on the last episode we did reviewing some of the anesthesia type workup and the various health reviews and things we can do and make sure we're safe with our pre-op type workups. It's a very dry topic. However, I just got several people saying that was great. And I love Dave Salomon. What a classy guy for delving into that dry material.
You know, someone's got to do it.
Exactly. Yep. Well, hopefully today we got something a little more exciting. We're going to do some case reviews. These are not purely anesthesia like we've done in the past. These are kind of all over the place with different just issues. And I would classify these more as kind of like near miss cases, you know. And so there's something to learn, I think, from all of these. Nothing too crazy happens, but they're very interesting. I'll tell our listeners you can find most of these on the MedPro website. It's oms.medprodental.com, medical protective. So they're a liability insurance carrier. Probably the next biggest one compared to OMSNIC. I use MedPro actually. And anyways, they
Little plug right there.
there you go. Yes. I'm happy with them, although OMSNIC is fantastic. I don't want them coming after me and to knock me off with the Chicago Mafia. Anyhow. All right. So got a good cases. So I'll just kind of read through / summarize some of these cases. We'll get your opinion. I'll throw in my thoughts. Any listeners that have thoughts about these cases, feel free to text or email your comments to me, and I can respond and maybe bring them up in another episode. All right, so first case, just going to run through some of the background on this. These are made-up names, so we don't know their actual names, so I just kind of plugged in some names. So we'll call him Dr. Charles, and the patient is Rhonda. So Dr. Charles was in an oral surgery practice in an affluent community, been out of school for nearly 10 years. He completed residency training and took courses focusing on the full spectrum of facial cosmetics, including becoming proficient at dermal fillers and other types of things like that, Botox, etc. In his state, they permitted Dr. Charles to do all these things. He was practicing legally, had a lot of significant experience, felt very comfortable doing what he was doing. His patient, Rhonda, had been seeing him for these cosmetic procedures for more than 4 years, exclusively for dermal fillers around the lips to smooth out lines and wrinkles that she found aesthetically unpleasing. She liked the fact Dr. Charles performed this treatment and had really subtle changes in her appearance. She didn't, the quote was, she didn't want the whole world knowing that her facial look was unnatural anyway. So she's doing what she considers to be kind of small procedures, and it is very important to her that no one knows. Okay, so following Rhonda's most recent visit, Dr. Charles, Dr. Charles' office sends an email, a link to Rhonda asking, it's linked to a popular online rating site and asking for her to kind of fill that out. So Rhonda gives Dr. Charles the top assessment category. She carefully words her narrative entry to read, quote, Dr. Charles is the best. He does great work and his staff is so friendly, unquote. So when Dr. Charles read the review, he's very appreciative of the kind words, and he responds in this public forum. Um, and his response to it is, "So happy we could make you even more beautiful with our magic injections." Okay, so Rhonda becomes very upset with this response. She was purposely, trying to not mention that the fact she was receiving cosmetic treatment from Dr. Charles. I think he kind of mistakenly didn't realize that and just off the cuff probably responded the thanks and mentioned that it was cosmetic type treatment. So the next morning, Rhonda calls Dr. Charles to tell him how upset she is about the post. She points out that she had been very careful to be vague in her post and that she wanted that to be protected and unknown, and that now he's kind of exposed it to the public. Dr. Charles repeatedly says, "I'm sorry," apologizes, and he tries to do whatever he can, but he's unable to calm the patient down. She threatens various types of legal action. When their conversation is ended, he immediately contacts the online site requesting that a response be taken down. The site, however, had a number of criteria, and it took time, quite a while, before it could be removed. Then Dr. Charles calls Rhonda, explains what he had done, and she becomes even more upset that it would take, more than just a day to remove this post. So the legal action response is Rhonda reaches out to her attorney. She wants to sue Dr. Charles for malpractice. Attorney explains to Rhonda that Dr. Charles had done nothing improper from a dental standpoint, and that she suffered no damage as a direct result of his care. When Rhonda asked whether Dr. Charles had done anything wrong, her attorney said that he might have violated her privacy rights under federal law known as HIPAA, which protects a patient's personal health information, including that she had been treated and what type of treatment she had received. Um, and so that's basically the main infraction here is just a HIPAA violation. So Rhonda does what she can, which is filing a board complaint against Dr. Charles. And in a time period in which Rhonda found excessively long, the agency or the dental board contacts her, obtains her verbal response, gets copies of online posts, looks through everything, takes a while. She's not happy about it. And the basically it says Dr. Charles received a government request for his recording records regarding Rhonda. He has to give all this stuff. I don't know if you've been through this process, Dave, but kind of a lot of back and forth trying to get the board the information they need. And their basic response is that he was not in violation of any laws in doing what his response was, that it was an accident. There was no malintent. And it's not long before Dr. Charles' attorney received notice that a significant fine was being levied upon Dr. Charles due to his having breached Rhonda's private personal health information without her authority. The attorney later explains that Dr. Charles, that his intent was not an issue, but the mere disclosure of that information. And so he has to pay a fine. He pays the fine. He learns that the state dental board had been provided with the records and findings, but it opted against taking any further action. So basically, the dental board said there's really nothing other than paying a fine for a HIPAA violation. Okay, let's stop here. Sorry, that was kind of long to explain all that. But Dave, what are your thoughts on hearing a case like this?
I mean, I think it's a little bit shocking that somebody would bring suit for something like that, but I guess that's kind of the point of discussing this. I mean, when I first read that, that's what I thought. The second time when you went through it, I'm thinking, actually, it's not, you really just shouldn't respond to any online review because good or bad, it's just, you don't necessarily need to engage. And I think, without an HR department or somebody else who really can manage that, I think it's just a better idea for the surgeon never to respond. That being said, I mean, it sounded like an innocent comment, but in today's, litigious world, literally anything you say can be held against you. So I guess the lesson here is just less is more. Don't interact online in any way.
Yeah,
That's my takeaway, at least. I mean,
probably the safest bet. Um, I mean, because the next question is, well, how much do your comments and responses to what people post does that really, is that a game changer? Or patients, oh my gosh, that's wonderful. You responded to my thing. I'm going to come more to your office.
Yeah.
I doubt that. I doubt there's a big return on posts, right?
Right. I think people like to see that a doctor has, a 4.8 star rating out of 200 reviews. They don't look to see if the doctor commented on every one. And I think that might be even a little weird if you are. So I don't
Right.
know. I mean, it seems I guess I have mixed feelings on this. It's silly and he meant no harm by it, obviously. And I don't think it's warranted. But then again, the HIPAA entity is so big and so powerful that you just really can't slip up at all.
Yeah,
So it's one thing, in your office with pieces of paper, but it's like once you put something online, it's there forever, like this podcast.
that's right. Exactly. Yep. And I think that's the good point, is maybe sometimes you kind of forget that anything that is public that does go online, even if it's a response on Instagram, on Facebook, right? In these forums, it's considered public, and we kind of forget that that could be a HIPAA violation, HIPAA infraction.
Yeah, and I wouldn't even think what he said was because he didn't say exactly what was done or why it was done. So I don't know. That's kind of a soft interpretation, maybe. I mean, he mentioned injections. That could mean a ton of things. That
Yeah,
could mean that he gave local and took a tooth out. I mean, did an implant, made her beautiful. That's what I would have argued.
made you beautiful with that magic local shot, and
You're
yeah,
beautiful by taking out that perio tooth. No.
no, yeah,
Now
it's
I'm
a good
worried that I'm
point.
going to get in trouble somehow talking on this thing.
You probably will, but don't worry, I've got a good attorney. Um, no, I know this is a wimpy case, and probably listeners are like, "Oh, that was stupid," but
Like
I
next,
think it's a good, just a reminder of being very, very careful in any public forum, especially social media. And I'm sure that guy just whipped off that comment, like probably not even thinking about it. And I
right?
mean, totally came back and bit him in the butt and created a lot of problems because in the end, right, it doesn't seem like that big of a problem. Yeah, he had to pay a violation and the board said slap on the hand, nothing really to do.
Legal fees and
Yeah.
stress. Yeah.
Legal fees, the stress, all the time it took to get the board and the documents. I mean, the harm she could have done by telling friends that, hey, this guy, it outed me on social media. Who knows? So just be careful and be super conscientious of what you're saying and anything in a public forum.
Yeah, and I mean, I guess there's multiple opinions on responding to reviews, but if it's going to be done, it needs to be done in like a very HR protective way and not directly from the doctor.
Yeah, exactly.
We're sorry you had a bad experience. Please call us and we'll discuss, I don't know, something like that. If you're going to respond at all, but
Yep. Excellent. All right, let's move on to our next case. So this is a case of involving a patient having a seizure. So we'll start this off. We'll call this patient or this doctor, Dr. Hansen, in mid-career. I believe it's a female, not that that matters. She's experienced practitioner, does implant dentistry. She's an oral maxillofacial surgeon. James, he's a male, 50-year-old male with a disclosed history of hypertension controlled with medications per his history. No other medications or medical conditions known, so that's key. All this surgeon knew was that James was 50 years old and had hypertension and it was controlled. So, important point to remember there. He came to the office for implant at number 30 site, which had been gone for 3 years. X-rays, everything looked normal, pretty standard implant case. 13 millimeter implant was chosen to place into a radiographically measured 15.5 millimeter space, which was superior to the infraalveolar canal. The patient saw no reason to be sedated for the procedure. He'd always been comfortable just doing regular stuff under local, so that's what he did. did a thorough informed consent. Yeah, we'll say Dr. H delivered a long buccal block as well as infiltrations around the area using 2 carpules of local with epinephrine. James tolerated that well, was numb after a few minutes. Doctor tested it. Okay, good. We're all numb. She elevated soft tissue flap with the mid-crustal incision. This is what most of us do. After reflecting flap, it sounds like James became noticeably jittery and started moving around with quote unquote odd opening and closing movements of the jaw. Okay, then it says Dr. H attempted the implant osteotomy. She briefly stopped working, but then began again. Patient was starting to do more of these jittery movements, and it was clear at this point that he was having a grand mal seizure. Before, however, she was able to stop the burr and remove the handpiece from the mouth. The osteotomy burr pierced through the buccal soft tissue and lower lip on both sides of the commissure. With Dr. H's assistant and instruction to her staff, the chairside assistant and Dr. H protected James from causing injury to himself and others while the receptionist called for EMS. By the time the ambulance arrived, the seizure had ended, with James appearing to be in an altered state of awareness. Dr. H placed the gauze over the lacerations and maintained hand pressure on them to minimize bleeding. James was transported to the local medical center where post-seizure care was provided and where oral maxillofacial surgery residents repaired the lacerations, debrided, and closed the crustal incision. So James remained an inpatient for a complete neurological workup, which never reached a conclusion as to the cause of the seizure. After returning home, he shortly resumed his activities while remaining under the watchful care of the neurologist. The scar that developed had a keloid appearance, which bothered James greatly. Despite 2 scar revision procedures performed by a plastic surgeon, James was constantly self-conscious about his facial appearance, embarrassed to meet new people, both at work and his social life. So the legal action here is James seeks a malpractice law firm, and the attorney assigned to handle the case advises James that he should be filing a suit against Dr. H. After Dr. H was served and then assigned defense counsel by the malpractice carrier, the discovery process began. The usual discovery paperwork. James, through his counsel, claimed that his facial scarring was directly caused by the negligence of Dr. H, namely that she had failed to protect him against the events which took place by having a proper finger rest. She had failed to timely realize the prodromal stage of the seizure and to act upon that, and in delivering an excessive amount of local anesthesia so as to cause the seizure. So Dr. H's attorney gathers all the medical records and looks at all the post-seizure neurological workup from the medical center. They took specific note of the fact that James's past medical history was as he had described it, and that the neurologist was able to determine the cause of the seizure, basically noting that there was no information, that was given to Dr. H to know that there was any seizure possibilities there, as well as the expert affidavits of a dentist and oral maxillofacial surgeon and neurologist. They sought immediate dismissal of the case by way of a legal approach known as a motion for summary judgment, MSJ. In those MSJ papers, the defense attorney argued with the backup of the experts that no finger rest could have possibly prevented the seizure from occurring. Without the seizure, there would have been no laceration to develop into a keloid. That seizure prodromal stages are individual to every patient, and with no seizure history, Dr. H could not possibly have foreseen a potential seizure, no less known the patient's prodromal signs, so as to interpret the quote unquote odd movements as being part of a seizure, and that the amount of local anesthesia was far from excessive, and so definitely not the cause of the seizure. So in the end, to skip through it, the Dr. H was not found guilty, and this case was dismissed. What are your thoughts here, Dave, on hearing this case?
Yeah, I mean, I'm glad to hear that it was dismissed because to me this seems ridiculous. I don't know how anyone could be held, responsible for a minor injury occurring when a patient has a seizure during a procedure when, I mean, sharp instruments are in your mouth, and if you start having a seizure, I mean, that seems unavoidable in certain circumstances. So yeah, I mean, I guess this points out the fact that you can be sued for anything, and I'm glad that this was thrown out.
Yeah. I mean, it's hard to say, what exactly without having all the specific details of when things are happening and what was going on and that type of stuff, what the surgeon could have done differently.
Yeah, I mean, maybe it was somewhat obvious something was going on, and maybe this doctor should have stopped the procedure sooner, but there's really no way to know that. And I don't even know how the patient would know that there was such a significant prodromal um, time frame that the surgeon would be able to tell and know that's what that was. I mean, like you mentioned, I mean, I think they can be pretty different amongst different patients. So
you know,
I'm just saying I don't know how the patient could claim that anyway. The patient is having a seizure. So
a couple of things that stood out to me. I mean, one is just the importance for sure of going over the medical record ahead of time. In this case, sounds like we're not sure how much was gone over, but luckily there was no history of seizure, right? Like
but
if
even if
you
there was, I mean, is there a contraindication to doing this, you know?
right. No, yeah, I think even if it was noted, I mean, like the attorneys pointed out, it was reasonable local. I mean, the only thing
Mm.
could have been, oh, well, the first jittery signs, the odd movements, and you knew, oh, this person is prone to seizures. Okay, let's stop. Maybe there's a seizure going on. That would have been just that first step of saying, okay, let's put this on hold. That could be the only thing I could think of.
A better finger rest.
Yeah, exactly. The
Yeah.
finger rest. It all comes down to the finger rest.
I love how the finger rest came up 6 times.
Yes. That is interesting. And of course, very unfortunate that the patient is a keloid former and this happened. I mean,
Or of course, yeah.
like,
Yeah, I mean, yeah, to your point, I guess this just highlights being thorough with your medical review and documentation.
so good stuff. It's also unclear, I think both us and the other one, we don't really know exactly what the conversations were that were happening between patient and doctor afterward. I mean, I know this could be, I assume the doctors contacted the patient and had lengthy conversations apologizing and trying to make things better. My experience is that if there's an infraction or some issue and a patient's upset, when I personally call them and apologize or say, at the very least, I'm sorry for this outcome. Maybe I didn't do anything negligent or anything, but when I personally talk to them and I'm, for, trying to find solutions and trying to help the patient, I have never had a patient all of a sudden just say, "Oh yeah, screw you, I'm going to sue you," or file a board complaint. Really, it's those. I feel like it's the patients who somehow slip through the crack, and I don't hear about it, and like a patient's getting upset because they're talking to a front desk person or somebody else, that's not me, and they feel
Yeah,
like I don't care. Like that's the message they get. Those are the people who do start instigating bigger problems, as they feel like,
yeah,
I don't know. What are
yeah.
your thoughts on that?
No, I totally agree. I think that's a huge part of dealing with bad outcomes, whatever they may be, um, is having empathy. And
Mhm.
if a patient and family see that you really care and that you're going to try to help however you can, whether that's revising a procedure or getting them to somebody or just talking it out, whatever. So those things, that kind of bedside manner has served me well. There will be times when something will happen and you think to yourself like, wow, this patient may sue me or could sue me, or I could see that happening. And if you have a good relationship or you can create that relationship, even in a when things are negative, that will probably save you 9 times out of 10 from, litigation. So for example, like I had that happen several times. And what's funny is the patients that you have in certain patients, if you have complications, if you are all of those things, or if you are, affable and responsive and proactive and have a good attitude and all of those things, sometimes you build the best relationships with those patients and you laugh about it later with them. So that's kind of a phenomenon I've noticed, that those patients where we've had a failure or a infection or something unforeseen, a complication, most of the time they stick it through with you because they trust you. There's some confidence there and they like you and they think you know what you're doing and they have confidence in you. Then most of the time those turn out to be like actually some relationships, not maybe long term, but just like you laugh with these people and you've seen them through something. You know what I'm saying? And so
Yeah.
I've seen that time and time again. And then the other thing is just, if something happens, definitely something negative, a bad outcome, definitely apologize to patients. But you don't necessarily, that doesn't necessarily mean you did something wrong. For example, when I'll say something like, I'm sorry this has happened, or I'm sorry this is happening, and I'm going
Yeah.
to help you through, and I'm going to help you as much as I can in any way that I can help you. And most people are pretty reasonable with that.
Yeah, I totally agree. Yeah, I say sorry very quickly, all, almost every day. I'm sorry, for like the dry socket patient who's following up. I'm sorry that this procedure's caused you so much pain. I'm sorry you've been in pain. This is horrible. I hate the fact that you've been going through this, and just sit with the patient and listen to them. Like, that really sucks. I'm so sorry this is happening,
Yeah,
and
and listen to them, let them get it out and talk.
yes, absolutely.
I think when patients feel rushed, look, we've all had situations of where we didn't handle it properly, sure, but I think when they feel rushed and they're not heard, then they basically just have to like you. And I think this goes
So
back
true.
to like the first time you meet them, the
Yeah,
consultation, really getting a variety of people to be able to like you quickly is a skill. And that's going to save you most of the time, because most
for
people, I
sure.
think, aren't going to sue you if they like you, they think you care, and they think you're actually good at what you do, and they understand that that was just something negative that happened.
I totally agree. It's so critical. They like you. I think too, I don't know why, but for some reason, I think, and it seems like this is more the case with a surgeon compared to a general dentist. Maybe that's totally wrong, but I think when something bad happens after the fact, oftentimes a patient comes in and says, this happened or that happened, we can become very defensive and say, oh, you're attacking, my ability as a surgeon, and you're criticizing me. I didn't do anything wrong. I did the best surgery possible. And we can get caught up in the weeds of like, being feeling threatened for our abilities, and not seeing the whole picture. Like, hey, this most patients, and even if they are attacking you, maybe, and they think, oh, you did something negligent, that's why I have a dry socket. I'm always like, I'm so sorry you're experiencing this bad outcome, that you're having these things. I honestly feel like we did the best we could, but sometimes this stuff happens. And like you're saying, it's okay to say sorry for the bad outcome, but be careful not to get into a defensive space and a defensive stance of,
Yeah.
put your dukes up, let's do this. I'm the man or whatever.
Yeah,
Anyhow,
definitely. Of those things I was listing, then I would add humility.
yeah,
Don't be the doctor, I know everything, I'm never wrong. I mean, I say that even when things are difficult diagnostically. I'll say something like, "Oh, I think it's this. I could be wrong. I rarely am." No, just kidding. But you say something like that, and they know that you are thinking and you're not just brushing it off and saying, "Okay, it's this,"
yeah,
and that you are honest. I mean, that's what people really want. You'd rather go to a practitioner who is pretty good but is honest than somebody who, is like has that ego where they'll never admit that they're wrong. Or,
yeah,
I think we've all seen it a lot where practitioners, especially, residents and things, will just quickly come to a conclusion because it's like a box to check. I'm moving on. Okay, consult done. It's this. But I think people, when they see that you are really thinking about their case, I think that helps too. I don't know, just
yeah.
that you're invested and that you're taking time.
Yeah, real quick here, Dave, I'm going to be vulnerable. A couple weeks ago, yes, this is a safe space. I saw a patient, an elderly woman, who needed an extraction of a tooth. I think it was an upper molar, and you know, sat down, talked to her. I think she was in her 80s, so definitely older, and kind of had a hard time hearing, and took some time, how's it going? What's bothering you? Okay, this is the plan. Seemed fine. I mean, the procedure went routinely. Finished, so, told her the post-op stuff. Assistant walked her out and like didn't think twice about it, right? It was totally fine. 2 days later, the patient's daughter, who's in their 60s, calls me on my cell phone because I give all the patients my cell, and she says, she's really upset and says, Dr. Stucki, I just want you to know you were very rude and mean to my mother. And I said, what? And she said, yes, you didn't even ask her how she was doing. And it's a doctor's job to ask how she's doing. That should be the first question you ask is, how are you doing? And I'm like trying to think back, I think it's been 2 or 3 days later. Like, what? I don't even remember any. I remember talking to her and it's going to find the conversation. I don't exactly remember all the specific things I said. And I said, oh, and my first instinct, right, was to be defensive and be like, whoa, hold on here. Like, we had a great conversation and this went well. And I just was like, no, I'm not saying any of that. All I said was, I'm so sorry that she had a bad experience. I'm really sorry. And the daughter said, yeah, I'm pretty sure you were super busy and you just didn't have time for her. And and I said, oh gosh, that it really wasn't our intent. We were trying to do everything we could to help her out, but I'm sorry she had that bad experience. What's going on with her now? Oh, well, she's having headaches. Okay, and so talking through all the problems she's having. Can we get her back in and take a look? We'd love to help her out. Yes, she'll come in this Friday. Okay, so we see her on this Friday. Her daughter comes with her, and the daughter's like all in a huff and I just kept apologizing. So sorry. We really wanted to do the best thing. Let's take a look in your mouth. And how have you been? And you're right. We're sitting there. And in the end, it just diffused all the anger. And by the end, they were laughing and joking, and like we're all best buddies, right?
Yeah.
But it's in that moment where you're like on the verge of like being like, okay, you're lashing out at me. Well, now I'm gonna lash out at you, and I'm gonna stick it to you because you're threatening me, but it just gets you nowhere. And so I've learned to kind of take a deep breath and just say, well, let me see this from their perspective. I mean, maybe we were rushed. Maybe we could have said more. And I don't know.
Well, yeah, that's a good example of what I was saying earlier, which is you can turn lemons into lemonade. And I almost pride myself on trying to do that whenever something negative happens and somebody's upset or there's less than ideal circumstance. If I can turn that around 180 degrees.
Exactly. Okay, here's our third, probably make this our final case. We appreciate our listeners who are sticking with us. This is one of a case that involves kind of basically a wrong extraction. So it's an 18-year-old high school student who's a softball player. She gets invited to the prom and she goes to her dentist. At the dental appointment, she asks her dentist about a couple of issues. She has two problems. One, she's got a painful upper right wisdom tooth that's partially impacted and it's like flaring up on her. She wants it taken care of. The other is she chipped her front right central, tooth number 8 is what we would call that, by being struck by a softball a few months prior. She wants that fixed. So general dentist, and she's talking to her dentist about this. He looks at everything, examines, takes x-rays, and he determines that the wisdom tooth needs to come out by the oral surgeon that he refers to, and that he's going to restore the central incisor before the prom, because that's what she wants to happen. So um, turns out she's very prompt with it patient, and she that leaves that office and goes over to the oral surgeons same day for the extraction of the wisdom tooth. And turns out she hadn't eaten anything, so she could be sedated. So Dr. G is the dentist. He instructs the office manager to call the oral surgeon's office to ask whether they could see this patient, we'll call her Sarah, to extract the upper right 8. So that's the quote on the phone, apparently. Extract the upper right number 8 or upper right 8. I don't think they said the word number. So the office manager speaks with Dr. O's receptionist, and they use Dr. G's exact words. And so they said, okay, send her over now. We can take care of her. So no written referral form or radiograph was given to Sarah to deliver to Dr. O, because this all happens on the same day. Not that it can't be done on the same day, but it didn't happen in this case. So she arrives at the oral surgeon's office with her mom. They go over medical history, and that she signs a consent form saying, let's see here. It says for extraction of upper tooth. So it's just this vague upper tooth is what's in the consent form. Okay, so they take a Panorex. She's seated in the treatment room. The oral surgeon introduces himself, reviews everything, the medical history, looks at the Panorex, and he has this handwritten note from his receptionist, and it says extract the upper right 8. And there's like a hashtag upper right hashtag 8. So he's looking at that. He injects sedative medications intravenously. Once the patient is sedated, Dr. O remarks to his assistant how unesthetic the upper right central incisor is, how it appears due to the spore accidents. So clearly she fractured it or chipped it pretty good, and there's a significant portion of it missing. He gives an anterior buccal infiltration with local anesthesia. And in the upper right central incisor region. When Sarah's mother came into the recovery room, she immediately saw that after the fact, of course, was all done, she saw that the front tooth had been extracted, and she began to cry. As Sarah listened to her mother, she thought it was an April Fool's joke, but it was not, because this was on April 1st. Again, another unfortunate event. Dr. O becomes very upset when he hears Sarah's mother and finds out why she's crying, and he immediately calls the dentist. And then he learns that the dentist, Dr. G, had sought the extraction of the upper right third molar, UR8, rather than the upper right central incisor. So apparently, this dentist is talking in ortho language and says UR8 or upper right 8. So, all oral surgeons right at this moment want to slap this guy's face, right? Like, who calls the frickin' tooth number 1 upper right 8? Okay, anyways, let's move on. So, and he says, yeah, I didn't want you to extract tooth number 8. In fact, the plan was to cosmetically restore that tooth. Both dentists then agree to work together to provide Sarah with an implant at the site of number 8 and do the crown, all at no charge. That treatment was ultimately carried out, but not before the prom. So Sarah attended wearing a flipper and felt very self-conscious. So unfortunately, there is legal action. We'll try to make this brief, but basically, they go to their attorney, and Sarah and her mom file a malpractice lawsuit against both doctors, the dentist and the oral surgeon, and they claim that the dentist negligently failed to properly communicate to the oral surgeon what the treatment plan was, and the oral surgeon extracted the wrong tooth and was negligent in doing an exam and getting all the right info. Okay. So then basically they say we're suing you, and this kind of spirals and it becomes very, I guess, sounds like a bitter situation between both doctors. And the dentist blames the oral surgeon and said, this is absolutely not my fault. It's all the oral surgeon's fault. I'm definitely not taking responsibility. In long story short, the oral surgeon says, yeah, I want to do whatever I can do to make it right. His attorneys advise him to settle with the patient. So they offer settlement. The patient accepts it. And Dr. G, the dentist, says, I'm not settling. I did nothing wrong. And he's very upset, and he's just says, no, I'm not doing anything. So they decide, okay, we're going to push forward with trial and go after the dentist for this. And then ultimately, the dentist decides that the stress and lost time from the practice having to deal with this case is too great. And he eventually agrees and makes a settlement payment on behalf, or the attorneys and everything make the settlement payment on behalf of him after much agony and kind of going through the initial steps of a trial. So, sorry, that was another long one, but let's get your feedback on this one, Dave.
Well, yeah, I mean, I think the one important thing that I take away from this is like it doesn't referrals, you just can never trust, and you really need to talk to the patient. So it's kind of different people do it differently. There's a timeout, whatever you want to say, but when you're meeting a patient same day or when you see him for the procedure the next time, you should be talking about what you're doing. So if the oral surgeon just said to this young girl, okay, we're taking out your front tooth, are we going to plan for an implant? I mean, there would have to have been some discussion so
Yeah.
that to me seems pretty avoidable in that way. sure, the referral was confusing, and maybe the tooth was non-restorable. It looked non-restorable, but typically in the right patient environment, you would be able to discern that. You don't just meet a patient, look at a referral, and take a tooth out without talking to them.
Yes.
So,
Yeah. And I mean, because I'm trying to picture it from this oral surgeon standpoint, maybe the patient comes back and she's kind of a shy teenager. He's maybe trying to talk, she doesn't say much. And it sounds like the mom didn't go back with her. It just seemed kind of like a comedy of errors that potentially could have resulted in this. But I mean, I think you hit the nail on the head. Is this is a big communication issue,
I
and
mean, I could see
yeah,
that sort of thing happening with premolars, and it's like, oh, they wrote number four, but you took out five because whatever. You should still pay attention. But my point is, if an orthodontist wrote number four and you took out number five, I'm sorry, if you took out what they wrote, but they meant a different tooth and they wrote it wrong, then it's hard to say that that's your fault. But in that moment, because these are premolars and it's ortho, versus like if you're taking out a front tooth on a person, I think there's more of a discussion. I'm not saying one is better than the other, but I guess what I'm saying is like there are certain circumstances where I think you would be talking about it. A lot of patients, my point is they don't know, oh, is it this premolar or that premolar, but they'll know if their front tooth is planned to come out.
yeah,
Um, that being said, I see a lot of patients shockingly often where I'm like, okay, your doctor sent you over for, you might say tooth number 19, or you might say a lower molar. And more often than I would ever expect, they'd be like, oh, I thought it was an upper tooth, or I thought I was having this one. It's like they don't even know why they're there. So that's kind of the counterpoint. But
yeah,
again, in a teenage girl, I think she's going to be aware if there's a plan to remove her front tooth.
yeah, yeah. And it seems like um I don't know, it seems like there's a lot of like they're rushing and it's all happening on the same day. It's like it's this Swiss cheese model, right, where all these holes are
Yeah.
lining up together. They call the front desk. It just so happens that this guy uses the terminology up, the ortho upper right eight, and she has that upper right eight, and it's it's just
Yeah.
crazy how this all comes together. And it's odd, of course, like you think you're reading and the staff member writes down on the paper, extract the upper right eight. Like that
Yes.
itself would be kind of strange. You'd be like, wait, what? Like that's a strange way to say it. Who says extract an upper right eight when you're meaning number eight? That's just a weird thing to say.
Right. It makes me think of early in my practice, I, s- I, so our front desk will print out the consent forms when the patient gets there for the procedure. And they were filling in the procedure. And it didn't take long for me to realize that some of the time it was wrong. Like it just, they'd say whatever it was, they'd say take, extraction third molars, but really it was only two of them or whatever. They were wrong often enough that early on I said, just, please don't fill these out for me. Just give me a blank consent form, like the appropriate consent form, and then I'm going to review it with the patient, which you should anyway. So anyway, to me, that's another way I fill it out myself.
Yeah,
You know,
I like that.
so that's a fail safe of saying, hey, we're taking out your front tooth, and she would be like, oh no, 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 no. So you know, I think doctors should fill out their own consents, is what I'm saying.
I agree. I think also too, we have multiple, like I don't extract a tooth without verifying it through at least, I want to say, three different methods. I'll always have a written referral from the dentist, right? I'll always ask the patient what tooth are we taking out, so they're giving it. And then we're looking at an x-ray, and we also have a financial agreement that is the patient agreed to do that. That's another one. And then I'll always look at the x-ray, have it in front of the patient, say, and point to it. We're taking out this tooth, whatever, right? And well,
Mhm.
looks good to you. I'm always trying to do this like multiple times. And yes, there are patients who like get annoyed and like, why don't you know what tooth we're taking out? Right? You get some of these people who
Yeah.
are It's like, hey, I'd much rather go over this ad nauseum and make sure we get the right tooth than rush something through and, take out a wrong tooth.
Mhm.
So I feel like you have to have some fail safes. You have to have at least, a few ways to identify it.
Yeah.
Um, yeah.
Yeah, these are good points. I guess it makes me think of I kind of developed a system for myself. So I used to, you know, open their chart and I would open their note, the note that I wrote, and it would say, you look at that and it would say extraction, blah, blah, blah. But I'm going to be vulnerable, Grant. I've made mistakes. I've written wrong teeth in a note. I have.
Hmm.
And
Yeah.
so now what I do is I check the plan in the system. What did I treatment plan? And I check my note and I check the referral. Even though I'm saying not, of course, not same days. I'm saying like you check all of those things. And if something doesn't match, then you figure it out. So I don't
For
know. At
sure.
least for me, that helps a lot.
I'll frequently get like just today, and this is not uncommon, but it's like, okay, patient sits down, the referral note, it's handed to me, it's printed out. It says the dentist writes extract tooth number 15 cracked, and and it's circled and written. It's all 15. And I said, show the x-ray. It looks like we're taking out that upper left very back molar. I point to it and she goes, what? I thought it was the second to the back one. Isn't it this one? And she's pointing to 14,
Hmm.
right?
Hmm.
I'm sure you've had this experience and you're like,
Yeah.
okay, let's stop the show. Let's look at this. Let me
No, I just take out
examine.
both. Just take out both of them.
Right. And like, because I always want to hear the patients, because I mean, 90% of the time, 99% of the time, it's the patient's wrong, right?
Hmm.
Maybe not that much, but oftentimes the patient isn't wrong and the wrong tooth was written down on the note and we're
Hmm.
investigating and the patient's like, we'll find out, okay, the patient is right. It is number 14. And
Yeah.
you know, so, and of course, today it was the referral was right. And we examined, and sure enough, 15 was cracked and 14 was fine. We show her, okay, she's good. All right, we take out 15. But there has to be that like
Yeah.
discovery. The patient has to be on board. They have to be talking. They have to be telling you what they think should happen. Because if it's at
Right.
all not in accordance to what that paper says or that electronic, document, you do not proceed.
Absolutely. Yeah. Yeah. So it seems pretty basic and obvious, but I think when moving fast, you things can be overlooked. So just take that extra minute to review
Yeah.
with the patient. It's that simple.
For sure. One question is, when you have like a teenager, like, do you always have that's being sedated? Do you always have a parent come back? Are you talking to the parent as well? Are there cases where the parent never comes back? They just stay in the waiting
I
room and that,
mean, yeah, so usually, yeah, for the sedations, I've met a parent at the consult for sure. But we'll do it where the day of it's up to, we leave it up to the patient and the parent. Like if they want to come back and sit there through the IV, that's fine. But if they want to sign the consent up front, that's fine. I still fill it out, but they don't necessarily come back and I don't necessarily talk to them before. But I guess I mean, we've already done a consult, so that as long it for me, so okay, it's a good point actually, because as long as everything lines up from my note to the treatment plan to the referral, then things should align. And most of the time, what we're talking about is wisdom teeth, so it's really not like, that common for there to be like some wrong site issue with that anyway. Premolars, again, as long as it's confirmed, I mean, and the parents confirmed in the consult, yeah, I don't have to see them that day, I guess, prior.
yeah, if it's a teenager, I always make sure I've had some conversation with the parent, that questions have been answered, we've verified the treatment.
Yeah, that's not a bad idea.
It's a yeah.
I,
Well,
there's like a protective idea of like, oh, don't bring the parent back if they don't need to, so we can get started,
yeah.
and and then they might stay for the IV and make it worse. So it's actually a
Hmm.
good point, I think, that you bring up that we probably should just have all parents come in the back.
Yeah, I mean, I think it's just one more fail safe. Because if he would have had this mom come back and would have talked about it, clearly the mom would have been like, "Oh no, we're not taking out the front tooth. It's the
Yeah,
wisdom tooth."
I guess in this situation, so what I'm referring to is where a consult's already happened, right? And now
Right.
this the second day. I mean,
That
yeah,
makes sense. Yeah.
true. I mean, it could have been 9 months ago, so nobody
Yeah.
remembers. But
Right.
to your point, I mean, for this case, it's like if it was all the same day, then I would have had that consult with them. So,
For sure.
but yeah, no, it's a good point.
With this write up, the from MedPro, they had an interesting sentence at the end of their summary. They said the importance of a timeout cannot be overstated. It is in its effectiveness in preventing wrong site surgery. A retrospective study of non-emergent surgeries at Vanderbilt Medical Center in 2016 and published in the Journal of Anesthesia and Analgesia in 2020 found that there had been no wrong site or wrong person surgeries when a timeout averaging less than 1 minute in duration had been taken prior to incision. JAMA Network publication from 2018 reported 95 wrong patient, wrong site, or wrong procedure operating room events in VA facilities, all taking place with no timeout or a faulty timeout. I'm not sure what that means. So just stressing the importance of a quote unquote timeout. I know this probably looks different for us in our office compared to at the hospital. You know how in the hospital the patients to awake, they haven't usually gotten anything yet, and it's okay, timeout. What's your name, patient? What's your date of birth? What are we doing for you? Everyone agrees. Okay, okay. Something like that, I feel like should be happening with every procedure. And like you said, we're probably doing that when we're talking to the patient at the beginning. I do it a second time right before I extract any tooth with my assistant. And if the patient's awake, a local. So before I put the forceps on the tooth, it's okay, extracting, I'll say extracting tooth number 14. And the assistant says 14. We look at the referral note, 14, and point to the x-ray. Patient says, yep, we're good. Take out the tooth. I know that sounds like very monotonous and probably ridiculous to a lot of people, but that's just what I do. It's like before that forceps goes on there, I'm saying, this tooth number and the patient and my assistant. At the least, my assistant is agreeing with me. It's kind of another second time out for me. And there's been times where it's like, wait, doctor, I think we're doing 15. Okay, let's check. Okay, it's actually 15. It's just one more thing. Do you guys do any time out, or do you stop and say, okay, let's verify everything?
I don't do it like the hospital setting, but I do kind of what you're saying, um, where I'll say it out loud and kind of wait for an assistant to agree. In fact, for like premolars, I mean, you could put up the referral and you could put up the x-ray side by side, but most of the time I'm working, I just pull up the x-ray. But for premolars, that are erupted, I don't need the x-ray. So I
Yeah.
pull up the referral and I keep glancing back at the referral,
Same, especially if there's
or
no
baby teeth.
braces.
Yeah.
Have you done it extracting premolars when there's
Right.
no braces on there and it just gives you the willies? You're like,
Yes.
oh boy, oh boy. Okay, four. As everyone agrees, it's four. The note says four. You okay?
Yeah. Premolars I think, give me the most anxiety.
Yeah. Our protocol, at least with our orthodontist, is of course they have that they're banded and they debracket the teeth that they want out.
Mhm.
I mean, that's the smoothest way to do it, but of course, that's not always the case. Anyhow, well, a good topic.
I would just, a final thought would be Dr. Ira Satinover, recall.
Yes.
He would say, trust no one. Everyone's out to get you.
Yes. The
And I live by
hypochondriac
that.
mentality. Yeah.
Right. Meaning the referral's out to get you, the parents are out to get you, everyone's out to get you.
You have to assume they're all out to get you, but luckily they're usually not all on the same page. So by talking to all these people, you will get to some conclusion about what's supposed to be done. Yeah, for sure. Okay. Well, good points here. Covered a variety of topics. Hopefully this has been of help to some of our listeners. I know I'll admit, and I know if you don't admit it and you're an oral maxillofacial surgeon, all oral surgeons wake up every night in a cold sweat with the dream of extracting the wrong tooth. That's okay. We can admit that it happens to us. Dave, you haven't had a decent night's sleep in years because of this recurring nightmare. Sometimes it's better to be a fool and make sure you don't operate on the wrong joint or take out the wrong tooth, and just make sure it's all initial. I do remember that. That's hilarious.
Everyone had a nice laugh on that one.
You can only imagine what patients are thinking, right? When you're like, well, I'm going to write my initials on your leg to make sure we amputate the right leg. It's just
Now,
like,
okay, one more thing. Sorry. I was telling a friend recently, friend of the podcast, about the story where you were sick.
oh, yeah,
The details, I don't know if we can tell the details on air, but I think I saved your life,
yeah.
because your head was going to hit the ground.
Thank you.
Um,
I'll
but yeah,
tell our listeners real quick. So, I had like the flu, like some stomach bug, and I had like been diarrhea all night. I wake up and I'm super dehydrated, like lightheaded. But of course, I have the military mentality of I cannot admit any weakness. So I go, we're doing like a double jaw starting off first thing that morning. And I just scrub in, and but even before I scrub in, I tell TJ,
you
our co-resident, I was like, "Hey, by the way, I'm sick and I haven't had diarrhea all night. I don't feel great." And he's just like, "Okay." So
you you warned me actually. I
did I
remember.
warn you? Yeah,
Well, you said, "Hey, if I might need a diaper in this case," something along those lines.
yeah. I scrub in, and I'm on one side, and Dr. Maloro's on the other side of the patient. He was on the right, we're on the left. That's how we do it. And he's going, and I'm like retracting for him. He's doing something, it's his osteotomy, and like all of a sudden I just start seeing stars, and I'm like, whoa. And I start muttering like, hey, I need to scrub out. I need to scrub out. And people are just ignoring me, whatever. And I just black out. My face goes straight down, like about to hit the patient's face. And apparently Dr. Maloro like grabs my head, I think, and right before it hit the patient's face, and he just kind of
Yeah.
like threw me over to the side, just kind of nudged me. So I just keel over to the side. And then Dave, being a faithful intern, like leaps under my body and grabs me before I like break my neck on the ground. And I wake up in like the recovery room, like, what just happened? And everyone's like
Oh
standing over me. What is going on? Are you Stucki? You're gonna die. And yeah, it was pretty ridiculous.
man, I remember it so vividly. It was
Dr.
yesterday.
Malaro didn't even miss a beat. He just like it's because like TJ was there and was like looking over and he's like, "Hey, what about Grant?" Dr. Malaro was like, "Focus on the surgery. We've got to get this done."
Yeah, I
Just like
think he asked if you had a pulse, and then I checked your pulse, and you did. So he carried on.
I think he even said residents are disposable. Someone else take his spot and carry him
That's
over to the meat factory across the street. They'll put good use to him.
that made me even more nervous. I was like, oh no. No, and then we took you to the PACU, hydrated you, and then you went to Northwestern for another case.
That's right. I just yeah. The life of a resident. Anyhow, that's another learning experience for those residents that are sick. It's okay to
Yeah, you should power through.
okay, power through. You'll be fine. Make sure your intern catches you. All right, Dave, this has been another amazing podcast. Hopefully, our listeners are, I'm sure most have tuned out by now, but some good cases. We're always trying to provide good content, and we just love the practice of oral surgery. And we love discussing cases, near misses, and problems, especially when they're not our own, right? It's always fun when it's
Right.
not your own.
Yeah, I mean, I think these are great reviews, and maybe we can do more.
Let's do it. All right, my man. Thank you. I hope you have a good night.
Very late here.
Yes, you're a
See what I
champion
did
for
for
doing this. So late.
Yeah. All right. Well, thanks. Thanks for having me again.
No problem. You're the man. I'll talk to you later.
All right. You too. Bye.
Thank you so much for listening to this episode of Everyday Oral Surgery. For more information on these podcasts, please visit everydayoralsurgery.com. I love feedback and would be very grateful if you would reach out to me via my email, grantstucki@gmail.com, and let me know what you thought of this episode. Or you can text me at 720-441-6059. Additionally, if you have any topics you'd like to hear about, or if you would like to be a guest on the podcast, please email or text me. I found many of my interviewees through people who have been contacting me and have been listening, and I've gotten so many great ideas for more podcasts, and that's what helps keep the podcast rolling. So really appreciate you making that extra effort and helping me out with feedback and knowing what to do next on the podcast. Thank you so much.